Smith and low sensitivity but a high specific for systemic LE. Systemic LE, lupus nephritis, mixed connective tissue disease. Epstein-Barr virus have been added. Antinucleosomes, and what is new? Antihistone, it is a drug. Antihistone, it is a histone, and it is drug-induced, specific, induced by drug, 100%. Again, this is the antibody, anti-Rho and the anti-La, neonatal LE, and subacute cutaneous LE. And again, look, last one, anti-ribosomal. This is for mixed connective tissue disease, ribosomes, diagnosis, and this is the mixed connective tissue disease with psychosis and depression. And this is the hepatitis-induced. Antiphospholipid syndrome, and this is with the high affinity, but it is diagnostic, very important lesion. And last one, anti-CPK, and this is the anti-ribonucleoprotein, mixed connective tissue 100%, 100%. And again, last but not least, this is لو عايز تصور حاجة والنبي صور دي فيها كل الديagnostic criteria كلها. A, it is Smith native DNA systemic LE. B, mixed connective tissue ribonucleoprotein. C, it is the drug-induced systemic LE. D, atherosclerosis and the crest. And the E, it is the diffuse cutaneous systemic sclerosis. E, it is the diffuse. F, it is the drug-induced systemic LE. And the G, it is the classic dermatomyositis. And the H, it is the antisynthetase. And the I, it is the amyopathic. After 2 years, you can diagnose it. Take care. بقى مخك تعبان مش عارف تحفظ ده كله، احفظ 3 سطور. حدهم لكم. انتي دبل ستراند دي ان ايه سميث سيستميك ال اي. ام اي 2 كلاسيك ديرماتومايوسايتس. جو واحد ده انتي سنسيتيز سندروم بتاع الدراج. اخر واحد ده اس سي ال بتاع سيستميك سكليرو. ما تحفظش اكتر من كده. يبقى this is what is new in the serology of systemic LE, and the key was to outrule the systemic LE. Take care. This is the classic type of the serology, and thank you.
شكرا دكتور عاصم.
بيقولوا الأسئلة في الآخر، هو قالوا لي
دكتور عاصم يعتبر في أسئلة.
شكرا.
دكتور عاصم is a well-known figure. We know him. He is a deep leader. And he's known also by the young generation. All residents who are in training, they know him, they like him. According to the instructions and regulations, we'll be having only one question. Please.
Thank you, Dr. Asim Farash, for your presentation. And now we will be with Dr. Sultan Al-Khnayzan, interesting cases from his practice. Dr. Sultan Al-Khnayzan is the consultant of dermatology, Department of Medicine, King Fahd National Guard Hospital, Riyadh, assistant professor, King Saud bin Abdulaziz University for Health Sciences. Dr. Sultan Al-Khnayzan.
Assalamu alaikum. So it's very difficult to be a lecturer, a speaker about after Dr. Asim Faraj. So next time probably I'll make sure that I don't come after him. So I'll present some teaching cases that hopefully will be useful because I learned from them many lessons. I used to collect these patients, and I collect challenging patients and patients with lessons and pearls and tips that I learned. And I did this lecture many times, but usually I always renew them and make a new harvest of challenging patients. Please do not take pictures because these patients give me permission to show them to doctors, but not to copy or photograph the slides. So please do not take pictures. So the first patient is this patient, 9-year-old boy with clear-cut pyogenic granuloma. So it's recurrent bleeding, and the problem here and the challenge is that the patient is afraid of needles. So he will not allow us to bring a needle near his nose and near his face to do curettage and electrodesiccation. So any solution? So we used timolol eye drops to shrink the hemangioma because after all, pyogenic granuloma is a hemangioma, and we applied timolol, 2 drops 3 times a day to the area, gently done by the mother. Please do not take photo. Please respect my wish not to take photo. So in a few weeks, the hemangioma started to shrink and then to get smaller and then fill off nicely and peacefully without any surgery. Actually, I did this for almost 3 patients or 4 patients, and all of them, they had nice resolution without intervention. So we have to remember that pyogenic granuloma can mimic amelanotic melanoma, but this is, fortunately, is rare in our skin type. And this is a report about using timolol. In one study, there was 4 out of 10 with complete response. Another timolol wonder, and this is with collaboration with Dr. Salman Saad from KQH, a 50-year-old male, previously healthy, presented with multiple painful ulcers. And we thought about vasculitic process or pyoderma gangrenosum. So biopsy came with suggestive of pyoderma gangrenosum, and there was no infection. So our clinical diagnosis was pyoderma gangrenosum, and we started treating him with prednisolone. Unfortunately, he did not respond. We added dapsone with partial improvement, and the patient refused to advance to immune suppressive treatment like methotrexate or other immune suppressive. So this was a challenge to us. So Dr. Salman Saad brightly thought about using timolol again for healing this resistant ulcer. The patient had 2 or 3 ulcers, so we used the leg ulcer as a positive control, applying timolol